hearing loss: causes, progression, treatments, and proactive measures. Hearing loss is a pervasive health concern affecting millions worldwide, significantly impacting quality of life, communication, and even cognitive health. While often associated with aging, hearing loss can stem from a diverse array of causes, some of which are treatable, while others require long-term management. This comprehensive article delves into the nuances of hearing loss, covering its varied causes, typical progression, specific laterality, single versus both ears, the range of available treatments, and proactive lifestyle choices, ensuring all our discussion points are thoroughly integrated. The hidden impact of medications, hypertension drugs, and hearing loss. A significant, though sometimes overlooked, cause of hearing loss is ototoxicity, where certain medications can damage the delicate structures of the inner ear. It's crucial to understand that while our focus here is on hypertension medications, many drug classes can be ototoxic. Among hypertension treatments, loop diuretics, e.g., furosemide, bumetanide, are the most commonly implicated. These water pills can disrupt the intricate ion balance within the cochlea, the spiral-shaped organ of hearing, by interfering with a crucial structure called the stria vascularis. This disruption can lead to a temporary decrease in the electrical potential essential for hair cell function, resulting in hearing loss and tinnitus. The hearing loss from loop diuretics is often temporary and reversible, especially with lower doses or discontinuation. However, with high intravenous doses, rapid administration, or in individuals with pre-existing kidney impairment, permanent damage can occur in rare cases. Other hypertension medications, such as ACE inhibitors, e.g., lisinopril, beta blockers, e.g., metoprolol, and calcium channel blockers, e.g., amlodipine, have also been rarely associated with tinnitus or hearing loss. The exact mechanisms are less understood but may involve effects on blood flow to the inner ear, or subtle alterations in neural pathways. Key characteristics of medication-induced hearing loss. When ototoxic medications cause hearing loss, it is almost universally bilateral, affecting both ears simultaneously, as the drugs circulate throughout the bloodstream. While the degree of loss might be slightly asymmetrical between ears, both are typically impacted. Progression of ototoxic hearing loss. This type of hearing loss characteristically begins with high frequencies. This is due to the tonotopic organization of the cochlea, where the base, responsible for high frequencies, is often more vulnerable to damage. Initial stage, high-frequency loss. Patients might initially be able to hear sounds, e.g., traffic, music, but struggle significantly to distinguish words, particularly high-pitched consonant sounds like S, F, T, K, TH, or SH. This often manifests as, "I can hear noises, but it's harder to tell what people are saying," or "people sound like they're mumbling." Tinnitus, ringing, buzzing, or hissing in the ears, is a very common companion symptom at this stage and often an earlier warning sign than noticeable hearing loss. Intermediate stage, spreading to mid-frequencies. If the ototoxic exposure continues, the damage progresses, affecting the mid-range frequencies crucial for overall speech understanding. Sounds might start to feel generally muffled or less crisp, and understanding conversations becomes consistently harder, even in quieter settings. Increased listening effort can lead to significant fatigue. Advanced stage, affecting low frequencies, profound loss. In severe and prolonged cases, the damage spreads to the entire cochlea, including the low frequencies. At this point, the patient will experience significant difficulty hearing most sounds, not just speech. Sounds become very quiet and indistinct, and communication without significant amplification or visual cues, like lip reading, becomes extremely difficult. What to do for suspected medication-induced hearing loss. If you suspect your medication is causing hearing loss, do not stop your medication immediately. especially for vital drugs like hypertension treatments. Abrupt cessation can lead to severe health crises, e.g., stroke, heart attack. Always consult your prescribing doctor first. Contact your doctor, prescribing physician, immediately. Inform them of your symptoms. Be specific about when you notice the symptoms and any changes in the medication's dosage, or if you started any new medications, prescription or over-the-counter. Your doctor needs to assess the situation and weigh the risks and benefits. Expect an audiology referral. Your doctor will likely refer you to an audiologist for a comprehensive hearing evaluation. This is essential to confirm the hearing loss, determine its type and degree, and establish a baseline or track changes. High-frequency testing is crucial here. For high-risk medications, ototoxicity monitoring with regular hearing tests may be implemented. Discuss medication adjustments with your doctor. Based on the audiologist's findings and the severity of your underlying condition, your doctor may consider dosage reduction, lowering the dose if medically feasible. Switching medications, exploring alternative, less ototoxic medications. Monitoring, if the medication is essential, strict monitoring of hearing will continue. Otoprotective agents, in very specific cases, e.g., certain chemotherapy drugs may be given to reduce ototoxicity. Manage symptoms. For permanent loss, an audiologist can recommend hearing aids or other devices. Tinnitus management strategies and communication coping skills will also be vital. If balance issues occur, vestibular rehabilitation may be recommended. What to do when medical help is unavailable, with extreme caution. If medical help is truly inaccessible, e.g., in a remote area, during a disaster, or without healthcare access for an extended period, your options are very limited. Do not discontinue critical, life-sustaining medications, like for hypertension, without medical advice, as the risks of uncontrolled underlying conditions are far greater. In such dire circumstances, focus on protecting remaining hearing, avoid loud noise. Optimizing communication with others, face the speaker, reduce background noise. Maintaining overall health as best you can until professional help is available. Beyond medication, a spectrum of hearing loss causes. Hearing loss isn't a monolith. Its causes are diverse and categorized by the part of the ear affected. Conductive hearing loss occurs when sound waves cannot efficiently reach the inner ear due to problems in the outer or middle ear. It often results in muffled or quieter sounds and is frequently unilateral, one ear, or asymmetrical bilateral, one ear worse than the other, but can be symmetrical. Common culprits include earwax impaction, the most frequent and easily treatable cause. Can be unilateral or bilateral. Ear infections, otitis media fluid or pus buildup behind the eardrum. Usually unilateral but can be bilateral, especially in children. Perforated eardrum, a hole in the eardrum from infection or trauma. Typically unilateral. Otosclerosis, abnormal bone growth in the middle ear. Often starts unilaterally but tends to become bilateral. Eustachian tube dysfunction, blockage of the tube equalizing middle ear pressure, e.g., from colds or allergies. Can be unilateral or bilateral. Foreign objects, typically unilateral. Benign tumors or growths, in the ear canal or middle ear. Usually unilateral. Congenital malformations, birth defects affecting ear structures. Can be unilateral or bilateral. Sensorineural hearing loss, SNHL, involves damage to the inner ear, cochlea and its hair cells, or the auditory nerve. This type is often permanent. Aging, presbycusis, the most common cause of SNHL, a gradual, natural degeneration of inner ear structures. Almost always bilateral and symmetrical. Noise exposure, noise-induced hearing loss, NIHL can be from acute acoustic trauma, e.g., explosion, or chronic exposure, e.g., occupational noise, loud music. Typically bilateral, though it can be asymmetrical if one ear was more exposed. Sudden sensorineural hearing loss, SSNHL, an unexplained, rapid loss of hearing that occurs over a few hours or days. Usually unilateral and is considered a medical emergency. Genetics/heredity, can be congenital, present at birth, or progressive. Can be unilateral or bilateral depending on the specific genetic mutation. Infections, viral, e.g., mumps, measles, rubella, meningitis, or bacterial infections. Can be unilateral or bilateral, depending on the pathogen and severity. Meningitis often causes bilateral profound loss. Head trauma/injury, fractures of the skull or direct damage to the inner ear or auditory nerve. Can be unilateral or bilateral, depending on the extent of the injury. Meniere's disease, a disorder of the inner ear. Often starts unilaterally but can become bilateral in about 30 to 50% of cases. Autoimmune inner ear disease, AIED, a rare condition where the body's immune system attacks the inner ear. Usually bilateral and often progressive, sometimes fluctuating. Circulatory problems/vascular disease, conditions affecting blood flow, e.g., high blood pressure, diabetes, stroke, can impair the delicate blood supply to the inner ear. Can be unilateral or bilateral. Tumors, an acoustic neuroma, vestibular schwannoma, is a benign tumor on the auditory nerve that characteristically causes progressive unilateral hearing loss, often with tinnitus and balance issues on that side. Neurological conditions, certain disorders like multiple sclerosis can affect auditory pathways. Can be unilateral or bilateral. Mixed hearing loss, a combination of both conductive and sensory neural components. Laterality depends on the underlying causes. Diagnosing the cause, a collaborative and thorough approach. To pinpoint the cause of hearing loss, healthcare professionals employ a systematic approach. Detailed medical history, the doctor gathers crucial clues about the onset, sudden versus gradual, laterality, one versus both ears, progression, stable versus worsening, associated symptoms, tinnitus, vertigo/dizziness, pain, discharge, fullness, past ear issues, general health conditions, diabetes, hypertension, thyroid issues, autoimmune disorders, kidney disease, current and past medications. Crucial for identifying ototoxic drugs, family history of hearing loss. And occupational/recreational noise exposure. Physical examination, an otolaryngologist, EN specialist, or primary care provider will use an otoscope to examine the ear canal and eardrum, checking for blockages, wax, infection, perforations, or fluid. Simple tuning fork tests, Rinna and Weber, can offer initial bedside clues about the type of hearing loss, conductive versus sensorineural, and laterality. Audiological evaluation, this is the most comprehensive diagnostic part, performed by an audiologist. Pure tone audiometry measures the softest sounds heard at various pitches and intensities in each ear, using both air conduction, headphones, and bone conduction, a vibrator placed on the mastoid bone behind the ear. This is crucial for determining the type, degree, and specific configuration of hearing loss. The results are plotted on an audiogram. Speech audiometry assesses the ability to hear and understand speech, including the softest level at which speech can be detected, speech detection threshold, the softest level at which speech can be repeated, speech recognition threshold, and how clearly speech can be understood when it's loud enough, word recognition score/speech discrimination, often with background noise, speech and noise tests. Tympanometry measures eardrum movement and middle ear pressure/function, detecting issues like fluid behind the eardrum perforations, or problems with the middle ear bones. Otoacoustic emissions, OAEs tests the function of outer hair cells in the cochlea by measuring tiny sounds produced by the inner ear itself. If OAEs are absent, it suggests inner ear damage. Auditory brainstem response, ABR, /brainstem auditory evoked response, BER measures electrical activity in the auditory nerve and brainstem in response to sound. This is particularly useful for infants, young children, or adults who cannot cooperate with behavioral tests, and also to rule out a tumor on the auditory nerve. Further diagnostic tests, if needed based on initial findings, doctors may order. Blood tests, to check for underlying systemic conditions, e.g., diabetes, thyroid, autoimmune issues, specific infections. Imaging studies, MRI, magnetic resonance imaging, for suspected tumors, like an acoustic neuroma, or other neurological causes affecting the auditory pathway, CT scan, computed tomography, for detailed visualization of bone structures in the ear and temporal bone, useful for fractures, cholesteatoma, or congenital anomalies. Treatment strategies, from medication to rehabilitation. Treatment for hearing loss is highly individualized and depends on the underlying cause, type, and severity. Medical and surgical interventions, primarily for conductive hearing loss or specific SNHL cases. Earwax removal, the simplest and often immediately effective treatment for wax-induced hearing loss. Medications. Antibiotics/antifungals, for ear infections, otitis media, otitis externa, that cause temporary conductive hearing loss. Corticosteroids, the primary medical treatment for sudden sensory neural hearing loss, SSNHL. They reduce inflammation and swelling in the inner ear. Can be given orally, pills, or via intratympanic injections, directly into the middle ear. Timely treatment, ideally within 2 weeks of onset, is crucial for the best chance of hearing recovery. Diuretics, for Meniere's disease, often combined with a low-salt diet, to manage inner ear fluid buildup. Immunosuppressants, for autoimmune inner ear disease, AIED. Decongestants/nasal sprays, can help with eustachian tube dysfunction by reducing congestion. Earwax softeners, ceruminolytics over-the-counter drops to soften earwax for easier removal. Surgery. Myringotomy and tubes, ear tubes for recurrent middle ear infections or persistent fluid, especially in children, to drain fluid and ventilate the middle ear. Tympanoplasty, repair of a perforated eardrum. Ossiculoplasty, repair or replacement of the tiny bones, ossicles, in the middle ear. Stapedectomy, surgery to treat otosclerosis. Tumor removal, if a tumor, e.g., acoustic neuroma, cholesteatoma, is causing hearing loss. Hearing devices, the primary solution for permanent SNHL. Hearing aids, electronic devices that amplify sound, making it louder and clearer. For hearing aids, the professional to see is primarily an audiologist. They conduct the comprehensive evaluation, precisely determine your hearing needs, select and custom fit the appropriate hearing aid style, behind the ear, BTE, receiver in canal, RIC, in the ear, ITE, completely in canal, CIC, invisible in canal, IIC, etc. Program them to your specific hearing loss, and provide essential follow-up care and adjustments. Modern hearing aids offer advanced features like noise reduction, directional microphones, Bluetooth connectivity, and rechargeability. While hearing instrument specialists are also licensed to conduct basic hearing tests and dispense hearing aids, audiologists offer a broader diagnostic expertise and often a higher degree of academic training. Over-the-counter, OTC, hearing aids are now available for adults with perceived mild to moderate hearing loss, allowing direct purchase without a prescription or fitting by a professional, though consulting an audiologist for guidance remains beneficial. Important. OTC hearing aids are not appropriate for children or individuals with severe or profound hearing loss, sudden hearing loss, or asymmetrical hearing differences. Cochlear implants, for severe to profound SNHL where hearing aids offer little benefit. These devices bypass damaged inner ear parts to directly stimulate the auditory nerve with electrical signals. They consist of an external sound processor and an internal component surgically placed under the skin with an electrode array in the cochlea. An otolaryngologist, ear doctor, often a subspecialist called an otologist or neurotologist, performs the surgical implantation, while an audiologist programs the device and provides extensive auditory rehabilitation, therapy, to help the brain interpret the new electrical signals as meaningful sound. Bone-anchored hearing systems, BAHS/bone conduction implants. These devices transmit sound vibrations directly to the inner ear through the skull bone, bypassing the outer and middle ear. They are suitable for conductive hearing loss, mixed hearing loss, or single-sided deafness. An ENT performs the implant surgery, and an audiologist fits the external sound processor. Auditory brainstem implants, ABA, are rare, highly specialized option for individuals who cannot benefit from cochlear implants due to a damaged or absent auditory nerve. An ABI directly stimulates the hearing pathways in the brainstem. Assistive listening devices, ALDs, and technology. These devices work alongside or instead of hearing aids to improve communication in specific situations, e.g., FM systems/remote microphones for noisy environments, loop systems for public venues, TV listeners, amplified telephones, captioning services for TV/phone calls/live conversations, and alerting devices for doorbells/alarms. Rehabilitation and support. Auditory rehabilitation, oral rehabilitation therapy to help individuals adjust to and make the most of their hearing devices, improve listening skills, and learn effective communication strategies. Tinnitus management, if tinnitus is present, which is very common with hearing loss, strategies include sound therapy, using background noise/maskers, counseling, cognitive behavioral therapy, CBT, and tinnitus retraining therapy, TRT, to reduce the perception and distress of the sound. Communication strategies, learning techniques like lip reading, asking for clarification, positioning oneself strategically in conversations, and managing background noise. Vestibular rehabilitation, for associated balance issues, dizziness/vertigo, a specialized physical therapist can help. Support groups, connecting with others experiencing hearing loss can provide emotional support and practical advice. Proactive steps, beyond treatment and medical help. While medical intervention is crucial, individuals can actively engage in lifestyle practices to support hearing health and manage symptoms. It's important to reiterate that these will not cure or restore hearing for permanent loss, but they can protect existing hearing, potentially slow decline, and significantly improve overall well-being. Noise protection, this is the most crucial preventive measure and can help preserve existing hearing. Always use earplugs, earmuffs, or custom hearing protection when exposed to sounds above 85 decibels, e.g., power tools, lawnmowers, shooting ranges, loud music venues, concerts. Reduce personal listening device volume and take quiet breaks after noisy environments. Healthy diet and nutrition supports overall health, which in turn supports auditory health. Emphasize antioxidants, vitamins A, C, E, from leafy green vegetables, colorful fruits, nuts, seeds, to combat inner ear cell damage. Omega-3 fatty acids, fatty fish, flax seeds, for anti-inflammatory benefits and cardiovascular health. Minerals, magnesium, leafy greens, nuts, zinc, meats, shellfish, and potassium, bananas, potatoes, are vital for inner ear function and protection. Folate, vitamin B9, and B12, deficiencies linked to increased hearing loss risk. Hydration, ensures good blood flow, vital for inner ear health. Regular exercise, cardiovascular exercise, walking, jogging, swimming, improves overall blood circulation, including to the delicate inner ear structures, ensuring nutrient and oxygen delivery and waste removal. It also helps manage chronic conditions, like hypertension, diabetes, that can compromise inner ear blood flow. Yoga and meditation, while not a direct cure, these complementary practices can significantly reduce stress and anxiety, common exacerbators of tinnitus, potentially improve blood flow to the head and neck via certain poses, and help manage tinnitus by fostering relaxation and promoting attentional flexibility. They improve overall coping mechanisms for living with hearing loss. Manage chronic health conditions, keep conditions like diabetes, high blood pressure, and autoimmune disorders well controlled, as they can significantly impact inner ear health and blood flow. Avoid smoking and excessive alcohol. These habits compromise blood flow and nerve function in the inner ear, accelerating hearing loss and exacerbating tinnitus. Auditory training and brain stimulation. These strategies focus on improving the brain's ability to process and interpret sound, rather than directly repairing the ear. This is especially beneficial for people who already have some hearing loss, e.g., using hearing aids or cochlear implants, as it helps the brain adapt and make the most of the auditory input it receives. This includes structured listening exercises, often through apps or with an audiologist, and engaging in mentally stimulating activities, puzzles, learning new skills, music training, to enhance cognitive function and neuroplasticity. Active listening practices, consciously engage with sounds, trying to identify them, their direction, and characteristics to fine-tune your brain's auditory perception. What doctor to see for hearing loss? The right professional. Knowing which healthcare professional to see is crucial for effective management. Your primary care provider, PCP, often your first stop for initial assessment, earwax removal, and referrals. Audiologist, the primary professional for diagnosis, evaluation, and non-medical management of hearing loss and balance disorders. They conduct comprehensive hearing tests, fit and dispense hearing aids, and provide rehabilitation for cochlear implants, offer counseling, and identify when a medical referral is needed. For most general concerns about gradual hearing loss, difficulty understanding speech, or tinnitus, starting with an audiologist is highly recommended. Otolaryngologist, EN doctor, a medical doctor specializing in ear, nose, and throat conditions. They diagnose and treat medical and surgical causes of hearing loss, prescribe medications for ear conditions, and perform ear surgeries, e.g., for infections, perforations, otosclerosis, tumors, or cochlear implants. See an ENT immediately for sudden hearing loss, ear pain, discharge, bleeding, severe dizziness/vertigo, or if a hearing test indicates an underlying medical issue. Neurotologist/otologist, an ENT with additional specialized fellowship training in complex ear and skull-based disorders. You would typically be referred to them by an ENT or audiologist for very complex cases like acoustic neuromas or intricate Meniere's disease. In many cases, an effective approach to managing hearing loss involves collaboration between an audiologist and an ENT, ensuring both the medical and rehabilitative aspects of your hearing health are comprehensively addressed. Conclusion. Hearing loss is a complex and multifaceted condition that can significantly impact an individual's life. From medication-induced damage to age-related decline, noise exposure, and various medical conditions, understanding its diverse causes and progression is the first step toward effective management. While some forms of hearing loss are treatable with medication or surgery, permanent sensorineural hearing loss often requires the use of advanced hearing devices like hearing aids or cochlear implants, expertly managed by audiologists. Beyond direct medical interventions, holistic approach that incorporates proactive lifestyle choices, such as noise protection, healthy nutrition, regular exercise, and stress-reducing practices like yoga and meditation can play a vital role in preserving existing hearing, mitigating symptoms like tinnitus, and improving overall well-being. Ultimately, early detection is paramount. Prompt consultation with the appropriate healthcare professional, whether your primary care provider, an audiologist, or an ENT specialist, for a comprehensive evaluation is key. With an accurate diagnosis and a tailored management plan, individuals can navigate the challenges of hearing loss, enhance their communication abilities, and maintain a high quality of life. Understanding and proactive care are your strongest allies in preserving this vital sense.